Good morning everyone, my name's Dane and I'm going to be talking about my project. So the title of my project is the use of FET PET uptake dynamics for the spatial characterisation of glioma. Essentially that means creating 3D maps of the brain using kinetic parameters. I would like to thank my supervisors, Martin, Rosalind and Pejman. So what does this actually mean? So I'm going to break down the title. FET PET refers to the type of images that I'll be looking at, positron emission tomography. These patients would have been injected with what is called an FET tracer. As you can see here, this is the molecule tagged with an F18 radioisotope. And this tracer is particularly good at imaging brain tumours due to its high uptake in these types of cells as opposed to healthy brain tissue. So then I'll be using this to look at the uptake dynamics of the tracer, looking at images in time and forming these time activity curves for both the blood, the plasma, and the tissue. Using these curves, I'll be able to create 3D maps and hopefully better spatially characterise where the glioma is and assess how aggressive it is. So a bit about PET imaging. So it's a functional imaging method that quantitatively measures biochemical and physiological processes. It's the most sensitive, non-invasive functional technique, which makes it very useful for the brain due to its very delicate nature. It measures the concentration of radioactivity, voxel-by-voxel, giving it the unit of becquerels per milliliter. Images are summed over a defined amount of time, forming 4D dynamic images. So glioma. So the focus of my project will be looking at patients with a type of glioma called glioblastoma. It's an aggressive cancer that begins within the brain, with glioblastoma being the most invasive type, which grows rapidly and commonly spreads into nearby tissue. Over 1,300 Australians died in 2016 due to this cancer. So it typically occurs in the frontal or temporal lobes of the brain, with diagnosis made up of a combination of CT scans, MRI, and tissue biopsy. Here's a diagram showing the stereotactic tissue biopsy, which involves removing part of the tumour and looking at the pathology and grading it and seeing how aggressive it is. So treatment involves surgery and later chemotherapy and radiation therapy to remove any residual tumour after the resection. So what's the relevance of FET PET and dynamic analysis? So the use of FET PET in glioma patients has been shown to accurately grade tumours, potentially offering an alternative method to invasive biopsy for diagnosis. It is favourable due to the deteriorating health of these patients, as most of them are on their last legs of life, and reducing any unnecessary treatment is very favourable. So other issues include pseudo-progression of tumours that appears in MRIs after the surgery due to a swelling treatment effect of chemotherapy. So utilising FET PET provides valuable information in assessing this elusive phenomena. So why is dynamic analysis helpful? So FET PET directly images the elevated amino acid metabolism of rapidly proliferating tumour cells. By observing how different voxels within the brain scan vary in activity over time, as shown by these curves here, the uptake of FET can be analysed to characterise whether a particular part of the patient's brain is experiencing glioma growth or not, and exactly how aggressive it is. So this project will involve me analysing FET PET images and data, which includes survival and progression information acquired from a 24-patient high-grade glioma patient study undertaken here at Sir Charles Gairdner Hospital. This project will involve extracting time activity curve features that include time to peak, late slope, and importantly, the uptake rate parameter, Ki, using Patlak analysis, which I'll explain in a further slide. By calculating this uptake parameter Ki voxel by voxel, 3D parametric maps can be created that give a much better idea of where the tumour is and how aggressive it is. Once I've found these parameters, I can potentially statistically correlate them with the patient's survival data. So the parameters in focus. So the most important one is the standardized uptake value, which is simply just the ratio of the image-derived tissue radioactivity to the whole body concentration of the injected radiotracer, which is simply found by knowing the dose given to the patient and the weight of the patient. It's typically used as the y-axis on these time activity curves, and a voxel with a standard uptake value of 1.6 or higher is usually considered cancerous. Other parameters include time to peak, which is simply the time corresponding to the maximal time activity value starting after roughly 3 minutes. The late slope will hopefully also be calculated, which is estimated by fitting the last few time points. This is quite a nice graph taken from a study by Vomacka, as it shows the different time activity curve shapes for the varying grades of glioma, where the bottom, where the red is the highest grade, the most aggressive, and the blue is the least aggressive, with this bottom curve showing the stable background value. So what is Patlak analysis? So it's simply a method for calculating the uptake rate of tracer from the blood and into the tumour tissue, where it becomes trapped. This is modelled by dividing the blood or the plasma and tissue into 2 separate compartments. Using PET images and segmenting where the artery or vein is, the concentration in the plasma can be measured, while tissue concentration is also measured voxel by voxel by looking at the entire image. Once these concentrations are found from the image, the following equation that links the 2 compartments can be solved. It's solved in a particular way, so we can then graph these 2 concentrations with, on the x-axis, we have our either our arterial plasma or the blood concentration, and with our y-axis being the concentration of the tissue radioactivity voxel by voxel. Once we graph this, we can use linear regression and find the slope, which will give us the uptake rate of the tracer. So that was Patlak analysis. How do I then create the maps from these parameters? So we're taking each of the images at different times. We're going to segment where the artery or vein of interest is. It's either going to be the carotid artery or the superior sagittal sinus vein, which is actually what the picture was before. Once we segment where the vein is, we can look at the concentration within that part, that region, and form these plasma time activity curves. Once we have those, we can apply our Patlak analysis using, this is actually a method outlined by Slicer, a program which I may be utilising. Once we have this plasma time activity curve, we can use the Patlak analysis and find our K value for each voxel. Using this, we can then remap it and replot it as a nice image. So what's the use of these nice parametric maps? So the parameter Ki mapped in 3D reveals improved information regarding the FET tracer uptake, and most importantly, the local aggressiveness of the tumour tissue. It has the potential to provide information not only for biopsy, surgery or radiation therapy, but also for prognosis, follow-up and prediction for tumour recurrence. It could also prove valuable for fast visual screening of glioma tissue by the radiologist or clinician. So previous literature on this topic is divided into 3 different categories. The first category I looked at was studies that assessed how these parameters are used to classify glioma. Vomacka in 2018 found that the dynamic parameter of time to peak allowed accurate identification of grade 3 gliomas, while Chan in 2018 was able to show the positive predictive value of FET PET with the maximum standard uptake value able to differentiate between high-grade, low-grade and benign tumour patient cohorts, with the Ki uptake parameter able to distinguish just between the high and benign grades. The other category was looked at the pseudo-progression and how these parameters can help predict or tell the difference between true progression and pseudo-progression. Pyroth found in 2011 that the tumour to background ratio, which is very similar to the standardised uptake value, is a sensitive tool to predict the treatment response in patients with glioblastomas at an early stage after radiochemotherapy. Kabaya found that the peak tumour to background ratio also, as well as the time to peak, showed significant differences between true progression and pseudo-progression. The final category I looked at was whether these parameters are very predictive in patient survival. So Janssen had 2 studies. The first study looked at the shape of these curves, and it was shown to be a strong predictor for the disease course of particularly low-grade glioma. Janssen in 2015 looked at the minimum time to peak value and found that it was the only parameter that had a powerful prognostic impact on progression-free survival and overall survival in high-grade glioma patients. So how is my project going to pan out? So I'm going to start off by attaining and verifying and hopefully characterizing these patient images into maybe their different types of different grades of tumor. Then I'm going to need to find the code that I'll be using to carry out this data analysis. Martin is currently talking with a collaborator who will hopefully provide me with a MATLAB code. If that falls through, I'm going to look at the slicer code method that I proposed before. And a big part of this will also be working out a method for finding this baseline plasma concentration. So once I've got the code and I've worked out a method to find this artery or vein concentration, I can then carry out my data analysis, define these parameters, and particularly the uptake Ki value, which I can use to remap in 3D and to provide much more comprehensive images. Once I have these images, it might be worth performing statistical analysis to find any correlations between my parameters and the patient survival data. And it may also be valuable to compare and verify any of my results with previous publications. So once I've done all this, I will interpret my results, summarize my findings, and hopefully write and publish my paper. Thanks for listening. Any questions?
So it's all about FET as the tracer, and the more common one to use is FDG, which is glucose. Why is FET better in this case?
Okay. Yeah, it's a good question. They found that the main benefit of FET, which I think it's also glucose, but is that its uptake in healthy grey matter and I think grey matter brain tissue is a lot less as opposed to FDG, which is still absorbed just as much. So when you use this FET tracer, you get a much better contrast in your images and a different sort of uptake by the tumour cells. So that it's found to be very much more beneficial for this type of diagnostic imaging.
And when you derive your maps, you get specific values in each voxel. What are some of the uncertainties, do you think, in those values that you derive?
So the most important thing is accurately segmenting where this artery or vein is to attain as accurate of a plasma concentration curve as possible. Because without that, because that gets applied to every single voxel value within, because I'm going to apply this Patlak analysis voxel by voxel throughout these images. And it's going to be very important to find as accurate a concentration curve as possible, otherwise it'll just generate a huge amount of uncertainty in these Ki uptake values. Previous literature has looked at sampling blood and to find directly using those blood samples to find the blood concentration instead, rather than extracting it from the images, which is obviously a lot more accurate, but the patient data I have does not include any patient blood sample concentrations. So yeah, that will be a big source of uncertainty. Any other sources of uncertainty is obviously due to partial volume effects that's intrinsic in PET imaging. Obviously when a positron is emitted from this tracer, it travels a certain amount of distance before it's annihilated with an electron, and it may not be annihilating exactly where it left off and creating blur in the image. But that's an intrinsic uncertainty which I can't actually change. But yeah, it'll be mainly focusing on trying to make these plasma curves as accurate as possible, because if they're not accurate, then all my uptake values throughout the image will be completely wrong.
Can the FET PETs be used as, can you sort of get the CT data as well when they do a PET CT, or does the FET tracer impact on the CT acquisition for a PET CT?
So are you talking if the patient has had a FET PET scan and then they go on to have a CT, or at the same time?
At the same time, when they acquire a PET at the same time as the CT, so that then you've got the data sets are automatically fused and together, and you can sort of see anatomical data as well as activity data.
Yeah. So what was the actual question? So will it influence, will this type of tracer influence
impact the acquisition of a CT?
Yeah, as opposed to FTG, the standardized tracer, I haven't read anything to do with how it influences the CT acquisition, but I can't see why it would make any difference at all.
That's great. Thanks, Amanda.